Good afternoon, ladies and gentlemen. Welcome to this session, Medtronic-sponsored session, remaining unmet needs and strategies in TAVI. So TAVI has been getting matured procedure and expanding this indication to low-risk cohorts. And we are accumulating our experience of TAVI. And this we now face a lot of patients getting into their younger age. So I guess the discussion in each heart team now is about what is the life expectancy of the patient and how the valve durability impact the treatment of choice in this field of aortic stenosis. So throughout this session, we will learn about each valve has its own valve design and tissue characteristics, so which could potentially impact the valve performance as well as the durability of the valve. So we will deal with this valve frame and those characteristics which impacts the outcome of the patient. I am delighted to co-chair this session with distinguished cardiac surgeon Michael Reardon from Houston, together with a lot of great panelists. David Roy from Sydney, interventional cardiologist. My great friend and brother, Gia Titsani from Cleveland, Ohio. And Dr. Kaguchi from Kagawa. Dr. Shinichi Shirai from Kokura Memorial Hospital. Congratulations for the great live case. And Dr. Watanabe from Tokyo Bay Hospital. So without further delay, I would like to introduce our first speaker, Michael Reardon. He will give us insights and updates of bioprosthetic valve durability, latest U.S. high-risk and TAVI results.
Well, Yuri, thank you very much. It's a pleasure to talk to you about durability. Durability, of course, is something that's going to be very important to us. These are my conflicts of interest. In background, transcatheter valve replacement really is an established therapy. We all know that now. We also know it's going to younger, lower-risk patients that we're seeing in our valve clinic who are expected to have longer survivals. So the lifetime management of these patients really requires us understanding bioprosthetic valve durability and failure, both in surgical valves and in TAVR valves. Now, the VARC-3 and the European consensus documents really define 4 modes of bioprosthetic valve dysfunction: structural dysfunction, non-structural dysfunction, thrombosis, and endocarditis. In this talk, we're really going to focus on structural valve deterioration, although I'll tell you that the overall bioprosthetic valve dysfunction will be presented at CRT this year by Steve Yakubov, the 5-year data. Now, we do have some pretty good data from the randomized trials that show out that 5 years. TAVR valves seem to be doing well, just as surgical valves do. But there's really limited data on the incidence and factors that are associated with structural valve deterioration after TAVR and surgery from large-scale, multi-centered randomized trials. Previous work we've done has showed that early generation intraannular balloon expandable valves actually had higher rates of structural valve deterioration. This is Pibero's work from Partner 2A showing the XT, which was the randomized valve, had significantly statistically more structural valve deterioration. In the non-randomized continued access S3 arm, it was 3.9 versus 3.5 in surgery, so no statistical difference. And this was considered a win because TAVI had done as well as surgery. We've done a prior analysis with the Evolut core valve superannular self-expanding platform that showed it had a lower rate of 5-year hemodynamic structural valve deterioration, and this might be associated with clinical outcomes. We have our longest data in the trial that Lars Sondergaard runs, the NOTION trial, out to 8 years, showing that both TAVR and surgery are doing relatively well. But one of the things that Lars and his co-authors did was they looked at the concept of moderate structural valve deterioration, and that's an increase of mean gradient of 10 or more from the last echo to the current echo, and a final mean gradient of 20 or more. And although this didn't reach statistical significance, you see it's trending in favor of TAVR. If we looked at actual valve failure, there's really no statistical difference. So we wanted to look at the 5-year incidence, outcomes, and predictors of structural valve deterioration in patients undergoing a core valve Evolut in the U.S. high-risk and intermediate-risk trials. So what we did is we looked at the randomized arms of high-risk and intermediate risk, which is over 2,000 patients, and used this randomized arm to compare the rates of structural valve deterioration between TAVR and SAVR. We then added in the non-randomized continued access to get over 4,700 patients so we could look at the association with clinical outcomes and the predictors of structural valve deterioration. Again, we used a definition of moderate or greater of an increase of 10 millimeters of mercury or more from the last echo after surgery to the current echo, and you had to have a final mean gradient of 20 or more, or you could have new or increasing intraprosthetic AR to moderate or greater. The Echo Core Lab at Mayo looked at all these. I had looked at a group with myself, Steve Yakubov, and Kendra Grubb. So we examined every one of these along with the Core Lab. We used a 5-year cumulative incidence of structural valve deterioration calculated from the randomized using a fine gray regression and interval censoring analysis, and we used death as a competing risk since a lot of these patients did die. We used a univariate Cox proportional hazard model to examine the association of structural valve deterioration as a time-dependent covariant with the clinical outcomes of all-cause mortality, cardiovascular mortality, hospitalization for aortic valve disease, or worsening heart failure. And the baseline characteristics associated with structural valve deterioration were identified using a univariate and multivariate fine gray regression, again using death as a competing risk. Well, these are the study demographics, and the randomized arms, as you'd expect, they are very well matched up. In the non-randomized arm, what we find is they're older, they tend to be more male, and they have a higher risk and more comorbidities. And this is the 5-year structural valve deterioration adjusted for the competing risk of mortality between TAVI and surgery. We see that surgery is 4.38, TAVR is 2.20. That's statistically in favor of TAVR. This is the first time we've actually shown less structural valve deterioration with TAVR versus a surgical valve. We then looked at a small annulus defined as an annulus of less than 23 millimeters on CT scan, and we see it again statistically in favor of TAVR. And in fact, it widens out. This valve has an increasing benefit as you move to a smaller annulus. When we looked at a larger, defined as 23 or greater, it's now trending towards TAVR, but it doesn't reach statistical significance. If we look at this, for both moderate and severe structural valve deterioration, they're almost all stenosis, very few regurgitations. And here's the money slide. This is the one you should take home with you. Whether you had TAVR or SAVR, if you had moderate or greater structural valve deterioration, it doubled your risk of mortality, all cause and cardiovascular, and it doubled your risk of hospitalization for heart failure or aortic valve reintervention. So even moderate structural valve deterioration is not a good thing, and it's strongly related to clinical outcomes. So who did and did not get structural valve deterioration? Those that did not get structural valve deterioration tended to be older, more often male. They had a more atrial fibrillation and more prior PCI. So who doesn't get it? Younger, healthier females. These are the ones that have smaller anuses who benefit even greater by a self-expanding valve. And if we look at the univariate and multivariate characteristics, again, the same thing come out. Older male, prior PCI, prior atrial fibrillation. PCI and atrial fibrillation, I can't really tell you why they get less. I don't know if it's because they're markers of heart disease and they die and death is a greater competing, or it's the anticoagulation. That's something we're still working out. And who got it more often? People with large body surface areas. Now, the limitation, of course, is this is just 5-year follow-up. In the intermediate risk and low risk, we're going to give you 10-year follow-up eventually. The contemporary criteria for structural valve deterioration from VARC3 really requires EOAs and Doppler velocity indexes. That was not collected in all these patients, and so we did not use that. I will say that we redid the analysis using EOA and Doppler velocity index. We lost about 20% of the patients because of lack of data, but it still trended in favor of TAVR. But we do see that these invasive gradients collected using Doppler are strongly related to clinical outcomes. So in patients that had intermediate or high risk aortic stenosis, if you had a self-expanding valve, you had less structural valve deterioration in surgery. And if you had it, it doubled your risk of mortality and it doubled your risk of rehospitalization. We published this in JAMA Cardiology. And my good friend on the panel, Dr. Tizani, did this really great meta-analysis. It's something I recommend that you go read. What he did is looked at all the randomized trials out there. And what we found is that Evolut Core Valve had less structural valve deterioration than either balloon expandable valves or surgery. And Evolut Core Valve had superior hemodynamics compared to either the balloon expandable valve or SAVR. So the clinical takeaway is if you want to give your patient the best valve for today with the only valve that shows superior hemodynamics at all time points and superior structural valve durability, you use a self-expanding supraannular valve. And that's something they live with every single day of their life, and it's not something that's 10 or 15 years in the future as a theoretical thing. Anyway, thank you very much. I'd be happy to answer any questions on this.
Michael, thank you so much for your fascinating talk. Please come back to the seat and please join the discussion. So I guess, as Michael nicely pointed out, this is the first transcatheter heart valve that showed superiority compared to the surgical valve in this randomized controlled trial study. So I would like to ask one question to Guy. You have nicely published this meta-analysis comparing balloon expandable as self-expandable valve and to the surgical valve. Based on these findings, both of you together, has this evidence impacts your treatment of choice for your getting younger aortic stenosis patients?
Yeah, that's a very good question, Yohei. Thank you for asking that. I think that as the meta-analysis showed, and as Mike showed on the data, right, we did observe that the self-expandable supraannular valve had lower rates of structural valve deterioration compared to balloon expandable valves as well as surgical valves. So every time we're dealing with patients who are younger, right, obviously we have to take a lot of other factors into account, right? Durability is not the solo factor, right? But as long as all of the other boxes are checked, definitely I do consider the fact that we have observed longer or better durability or less structural valve deterioration with these devices when I'm going to pick which valve I'm going to choose for that specific patient.
Thank you, Guy. And I would like to ask David as well. So each country or the region has its own kind of guidelines. Now, for patients with aortic stenosis, I guess the main factor for decision making is the age of the patient. So in your heart team discussion, what is the kind of age cutoff for TAVI procedure, and how would you choose the valve for this kind of patient?
Yeah, thanks, Ono. We don't have a specific age cutoff. We sort of use both the European and the American guidelines, but I think that lands us at about age 75. When they're under 75 and we're suggesting TAVI, the surgeons start to get a little bit twitchy. And really, I think it would only be in circumstances where the patients had elevated surgical risk. Once the patients are over 75, I think looking at mortality and things, I think certainly there's no disagreement that even if their surgical risk is low, then TAVI is something we lean towards. Mm-hmm. I think we are spending a lot of time talking about second procedures and things where actually, the most important thing, if you look at somebody who's 80 years old at 5 years' time, approximately 50% of them are not going to survive, with or without their valve, or with their valve treated. So we really should be ensuring that the valve we put in the first time is actually the best valve for the patient at that time, and sometimes the conversation has slipped a little bit away from that.
Mm-hmm. Okay, thank you, David. So Shinichi,
yeah.
So we have a nice comment from the U.S. perspective and the Australia perspective. So we still deal with quite high age patients, right? Most of the patients are over 80. 75 to 80 years of age is kind of gray zone. We can offer both options. So considering that age and life expectancy, how does this presentation that just Mike showed impacts your choice of treatment?
Yes, thank you very much. So in Japan guidelines, 75 to 80 years old is a discussion with the surgeons, which is a TAVR and a SAVR. But most of the high and intermediate case, 80% are this in high risk, and 55% is this in 5 years in intermediate risk. So maybe the durability is also the same, but also in high risk and in intermediate risk, even in surgical population, mortality is same in TAVR and SAVR. So according to the age is of course important, but STS score, risk score is also the key to determine which is better, so TAVR and SAVR. So, and then in our institution, the 80 years old is, of course, TAVR, but 75 to 80 years old with discussion with surgeon. But sometimes it contains a bicuspid patient. So, and in bicuspid patient, which should be better for treatment, the TAVR and the SAVR. So, and then, as you can say, so as you said, so second TAVR is possible or not is also the key to determine the treatment. Yeah.
Thank you. Lars, please.
Yeah, I'm just following up with what Shinichi is saying here, because we're talking about durability because we expect TAVI to expand to patients with longer life expectancy. And Mike, we have seen in the US that patients undergoing isolated aortic valve replacement who are younger than 65, half of those patients will go for TAVI today.
Well, I think it's not half of them, but it's a growing number,
Yeah, okay.
and it depends on the institution. You can remember in the randomized trials, in the partner trial, only 7% were less than 65, and in Evolut, only 6% were less than 65. So I always tell patients, we never tested, randomized trials only apply to the people, like population we tested. We did not test this population.
No, exactly, because I mean, we will expect it's going to
It will.
expand to younger patients. It's just a matter of time where it's going to be. And then we're going to see patients coming forward with bicuspid aortic valve, not tricuspid valve. Do you think we can use the data we got today on the durability of these transcatheter heart valve in tricuspid valve on patients with bicuspid aortic valve?
Well, we don't know, because we don't know if they're going to be out of round, and out of round is associated with valve failure. Obviously, if we operate on you, the answer is yes, because I'm going to put the same kind of valve in you. But we don't know, Lars. And although we've gathered some of the best data that we've ever gathered in our TAVR trials, there are still large knowledge gaps out there that remain to be filled. I mean, one of the things we want to look at is we know TAVI has an early advantage over surgery. It's easier, people do well. What we don't know is it going to maintain that advantage over time. We saw PARTNER 2A cross at 3 years. And at 10 years, we don't know what it's going to do. We see the low-risk PARTNER coming together at 2 years. So, we really need longer-term data, not only in bicuspid valves, but even on tricuspid valves.
Yeah. Does it mean we should just be cautious about not taking these data from tricuspid valve and say that can be used as an argument to use it in younger patients with bicuspid valves?
I think that's actually a very important point, right? Because honestly, we don't know whether or not there's going to be an impact of this, because it depends on the phenotype of the bicuspid, right? There are bicuspids and bicuspids, right? But obviously, if there is that bicuspid, you have a very calcified raphe, that you have even like an under expansion or uneven expansion of the transcatheter valve. And you can debate, well, if it's a supraannular valve, you're going to decouple the actual functioning valve from the annulus, right? But I agree with Lars. I think there might be an impact on the durability if you have we don't know the answer. I know that, right? But there might be an impact on durability. More to come. We're going to have to follow these patients up, but I think it's a very relevant point.
Yeah, I totally agree. It is a very important point. I guess recent publication from Minneapolis, actually, in circulation, showed that the valve deformation could potentially lead to increased rate of HALT, which could potentially lead to valve durability. We don't know the answer yet, but...
Well, we have to remember that bicuspid valves, the problem really isn't at the annulus. It's higher than the annulus. It's the geometry of the valve. If you only have 2 leaflets, you can only have R, 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 R. So it can only open to 4 times R. The circumference of the circle is 6.28 R. And so bicuspid valves are always like a volcano. They never open up all the way, and that's right where your valve sits.
Okay, so I would like to ask one question to Dr. Watanabe. He's an interventional imager. So from imager perspective, you follow the patients who had TAVI treatment, annually checkup basically by echo. And there's a data accumulating of valve durability, as Mike showed us. But it depends on patient to patient, right? So how can we predict the valve durability in each patient's basis? Do you have any tips and tricks?
It's a very difficult question because there are not enough imaging by echo or even with CT because the leaflet is inside the stent. Mm-hmm. So to predict something is very difficult. But and in my opinion, definition of this kind of deterioration is data upon the gradient or velocity, but not only these indices, but we need the stroke volume index or flow rate. That's a very important impact on prognosis of the patient itself. So I think the hemodynamic change is more important than the structural deterioration. It's my opinion.
Do you want some?
Well, no, just it's very interesting. When you look at gradients, there's a U-shaped curve of survival, and the very low gradients are often very low flow people, and that's why they don't live. And then it goes down where you have normal flow and low gradients, and then you have normal flow and high gradients. And so at both ends of the curve, they tend to fall out. But what I'll tell you is that this data shows that if you have moderate greater, it doubles your risk of dying. And so it's clearly important stuff, but it's nuanced, as you said, in a lot of ways. Now, I can predict whose valves are going to last longer. The older you are, the longer your valve is going to last. And the bigger your valve is to begin with, the better it's going to last. We've known that for decades of surgical work.
And your data nicely show that BSA obviously impacts the valve's durability. So, okay, so having said that, we would like to proceed to the next speaker, Dr. Kawaguchi. He will share us incidence, predictors, and treatment of HALT.
Thank you, Dr. Yohei. It's my pleasure to have presentation in this Congress. I'm talking about incidence, predictors, and treatment of HALT, which is a very important and unsolved problem of TAVI. This is my disclosure. As I might not need to explain, but HALT is an abbreviation for hypoattenuated reflex thickening, which can cause reduced reflex motion, and reduced reflex motion affect valve dysfunction. In transcatheter aortic valves, incidence of HALT ranged from 6% to 16%. However, the number does not reflecting all patients with HALT because CT scan is not performed for all patients. Incidence of HALT is different depending on valve types. In Portico, which is a former generation of Navitor, the rate of HALT is 22%, and in Sapien 3, 10%, and in Evolut Pro, 0%. In general, the rate of HALT is higher in intra-annular valve than in supra-annular valve. In two major types of THVs, the rate of HALT is higher in Edward Sapien series than in Medtronic core valve series. Although HALT formation is likely multifactorial, one of the important mechanisms of HALT formation is backflow stagnation in neosinus. Compared to surgical aortic valve, transcatheter valve is likely to form HALT because reduced direct communication between neosinus and anatomic sinus weakened washout effect. And low output was also reported to be increased the size of the neosinus stagnation zone. And other mechanism of HALT is endothelial damage due to overexpansion of valve. Many predictors of HALT have been reported previously, and orange squares show positive predictors for HALT, and OSC green squares show a negative predictor for HALT. OSC was reported to be effective for prevention and treatment of HALT. And these factors were mainly related to patient characteristics. Last year, a very interesting report was published. In this report focused on how valve expand, which means THV deformation. In this report, neosinus volume and the area surrounded by stent frame at some levels of THVs were measured and calculated prosthesis deformation index. And also asymmetric reflex expansion was measured in this report. Theoretically, full reflex expansion would be assumed to be 120 degrees. So asymmetric reflex expansion was defined as the difference between 120 degrees and each reflex angle at coaptation level. The result of multivariate analysis for predictors of HALT, factors related to THV deformation and smaller neosinus volume significantly affected the incidence of HALT. So it might be important to expand the valve as circular as possible. However, we should take care not to injure aortic root. That is trade-off. In terms of treatment of HALT valve thrombosis, anticoagulation therapy is effective for treatment. And the figure on the left shows a representative image of valve thrombosis resolution. A large amount of thrombus had been suspected at diagnosis, and after treatment, the low-density area almost disappeared with anticoagulation therapy. The figure on the right shows the impact of HALT on valve function and the serum NT-proBNP. At diagnosis, both of them became worse, and after treatment, both of them improved significantly. What is natural history of HALT? This is a sub-analysis from a Partner 3 trial. The red square indicates the TAVI cohort. In this cohort, from 30-day to 1-year follow-up, 50% of patients in HALT group showed spontaneous resolution of HALT. However, 23% of patients in no HALT group showed new HALT. And importantly, in this cohort, no patient received any anticoagulation. And OAC therapy is effective for treatment of HALT. However, residual HALT was observed in spite of OAC administration. And progression of HALT was not seen in patients with OAC at worst. However, progression of HALT occurred in 22% of patients with antiplatelet therapy or no therapy. What is the impact of HALT on valve durability? In pathological examination, it was reported that thrombus can cause organization and extrinsic calcification, and both of them can result in valve dysfunction. Calcification cannot be treated with oral anticoagulant therapy, so we might need to take some action before thrombus became irreversible. Clinical impact, in terms of clinical impact of HALT, the figure on the left showed 5-year follow-up data of HALT patient. In this report, there was no significant difference between HALT group and no HALT group in terms of mortality. However, structural valve disease is significantly higher in HALT group. And the forest plot on the right showed the ischemic stroke is significantly related to HALT existence. So this is a rough summary of HALT. In terms of mortality, there is no significant difference between two groups, and ischemic stroke is significantly higher in HALT group. And structural valve deterioration, it's controversial because other report says there is no difference between two groups. So we have to know, we need further examination about HALT for a long-term follow-up data. This is the last summary slide. I was talking about incidence and predictors and treatment of HALT. However, we don't know when to perform CT scan, what is the trigger to perform CT scan, or if treating HALT, how long the duration would be. Unresolved issues remain about HALT. Thank you for your attention.
So thank you so much for sharing the updates of the HALT, subclinical leaflet thrombus. Please come back to the seat. And Lars, do you want to?
Yeah, because I mean, this is a subclinical leaflet thrombosis is certainly a concern, but whether it's an issue, I think it's still too early to conclude it. First of all, I think it's very, very important to distinguish between subclinical leaflet thrombosis, where the patient have no symptoms, the valve is working perfectly fine, there's no gradient, there's no regurgitation, and clinical leaflet thrombosis, like clinical valve thrombosis, where you have a high gradient and a patient may be in heart failure. I think it's two very different entities, and they have never been linked together. And also, remember, it's a dynamic phenomenon. You say that in Evolut it was 0%. If you go into the Evolut low-risk trial, at 30 days, it was 17% of the patient who had it. At 1 year, it was 24%. So it is in all valves, and it's going to be there at 1 day. If you wait 3 months, it may be gone, or opposite. So, and if it really was an issue, I think we were going to see much more valve failure when we actually see. And valve failure, as Mike showed, is very rare with these TAVI valves here. And if, also about the stroke, remember, the CT scan looking for subclinical leaflet thrombosis was not done at the same time as the patient had the stroke. There was a temporal resolution between them. And since it's a dynamic phenomenon, you cannot link them. And finally, I would say, if you start to look for HALT in all patients, and we're going to treatment, I'm sure we're going to kill some patients, because Galileo trial, the popular trial, have shown that less is more in these patients. If you give them too much antithrombotic therapy, these patients will die. So be careful about drawing these conclusions, because I don't think it's actually supported by the evidence we got today.
Lars, when both the low-risk trials had these 4D sub-studies, and of course, I was part of the Evolut. The difference, of course, was in PARTNER, there was more HALT and SAPIEN than in surgery, and Evolut, there was more HALT and surgery than Evolut. But it was, I remember looking at the first data, it's very confusing. Some people didn't have it and then got it. Some people had it and it went away. And when I first looked at this with Jeff, it was like, well, what are we going to write about this? Because it was very confusing. And then it was the same core lab. Then we just went to 50%. So then the question, we all started thinking, should we screen everybody for HALT? Well, we don't. We don't screen you unless your gradient's gone up above 20. What are you using as your screening metrics? Who would you screen for HALT?
In my opinion, I would screen HALT if the patient mean pressure gradient became 20, or it means moderate structural valve deterioration.
But now it's not HALT.
Yeah.
Now it's clinical valve thrombosis. So it's two different things.
Yeah.
So my recommendation, don't look for it. If you find it, leave it.
Yeah, you sound like a surgeon now, Lars. That's how we think.
I think this is a very, very relevant comment, right? Because, again, we don't go after, or we don't look for it, right? But if the patient has a clinical manifestation, which is a different entity, right? Then it's time for us to react. From a practical standpoint, right? What is the message we want to deliver here, right? We're not going to look after it, right? If the patient is asymptomatic, just probably let go. We're not looking for it, right? However, if the patient has symptoms of the condition, increased gradients and heart failure, then it's probably time for us to, and obviously considering the risk of bleeding, right? I mean, sometimes, the risk of bleeding of these patients is going to be very high. So always considering all of the aspects.
So surgical valves have this. They've had it my entire career, going back over 40 years, and it wasn't until recently we even thought about it or looked for it. We didn't even know it existed. We thought that these were just early thrombosis. How are they doing in Australia?
Well, Michael, I was going to say that the American guidelines still, even for an aortic bioprosthesis, you still use warfarin for 3 months. Is that correct? Is that
so that has recently changed based on one study from Sweden. I don't, because I don't believe the study. But in my lifetime, it started with everybody getting warfarin so the knots would heal, to then everybody not getting warfarin because it didn't make any difference, and now it's back again. So it's like a lot of things in life, these things circle around. I think what you have to be careful of is you move to older patients, as Lars has said, you will kill older patients with oral anticoagulation. And so you have to be very careful about who you're going to treat. And if you treat them, Somebody comes in, their gradient goes up to 25, and you put them on Coumadin, and the gradient goes away. What do you do then? How long do you stay on Coumadin?
You mean the duration of OSC?
Yeah, how long do you keep them on oral anticoagulation?
In previous report, 12 weeks of OSC treatment is effective. However, sometimes it's difficult to find the dystrophy of heart because we shouldn't take CT again and again because of radiation and contrast media. So I would shorten the follow-up period and after detected clinical valve thrombosis.
Yoy, what do you do?
Well, I agree with Lars' comment. I don't overreact for the HALT at this moment, but if patient starts developing increased gradients over the follow-up, I will pay attention more closely. And then if the patient, let's say, develop mean gradient compared to the baseline 10 or more, then I have to go for maybe CT scan and further workup, as well as a further treatment option.
Excuse me, I have one question about I'm not certain of the difference between valve thrombosis and HALT. What a difference?
Well, so there's some good pathological showing that some of this HALT is probably early thrombosis that never progresses. But as Lars has pointed out, once you get a gradient, now you're affecting the valve function, and you are moving into valve thrombosis, which is something we've always known about, and you know it will get better with time. But you know we're actually collecting some of these valves and doing pathology on them right now.
So can we say the HALT is the process to go to the valve thrombosis,
Yeah,
right?
I mean, the way I look at it, and you know, Lars and others, I can say, to me, it's your valve starting to try to thrombose, and some of these fail and they get better, and some of them go on to real thrombosis. And all we do is we follow echoes, and if the echo changes, then we react to the echo change. If the echo doesn't change, we don't. You know, when we did the 40 studies, one of the things that we looked at is, well, what happens if you see HALT? Do you put them on OAC? And we didn't want to because we wanted to see what happened to these people. And that's why some of them got better. You know, we weren't putting everybody on oral anticoagulation as soon as we saw it.
I see.
I would like to encourage the audience to put any kind of questions or comments.
I won't say your name if you put in a question, I promise. You can be anonymous.
Dr. Fukui, please.
Yes, so that's the TAVI deformation paper is my, I'm an author of that paper. So I completely agree with you. I don't think every patient with HALT need anticoagulation. But what I wanted to show in that paper is, so if first thing is, if, you know, after, immediately on the senior immediately after procedure, if some deformation is observed, we maybe need to, I would maybe recommend to the maybe 30 days or 3 months after post-process CT, and if we, you know, how can I say this? So if HALT, the reason, so the main reason, if the main reason of HALT was heart deformation, maybe we should consider about long life anticoagulation therapy for that patient. But even if we observe the HALT, but less deformation, we could just follow up without anticoagulation. And the second thing, so if deformation is associated with the HALT occurrence, maybe that's the, you know, the opportunity to start to think about how we can change or modify the procedure, implant procedure, how, you know, get more fully expansion and avoid the deformation like an hourglass shape. That especially for sapien 3's hourglass shape, we found that the the asymmetric calcification distribution is an important factor to the hourglass shape. So if we could predict that thing with the pre-process CT, that might help to choose a valve selection, Evolut or Sapien or other valves. So I think that's just beginning of that, to start seeing the more appropriate procedure and valve selection to consider the TAVR durability.
Oh, thank you so much for your important comment. So you may consider thinking of anticoagulation if you observe a deformation plus HALT.
Yes.
So let me ask a question. So you mentioned that intraannular valves had more HALT than supraannular valves. But is it the position of the valve or is it the material the valve is made out of? Because if you look at the literature, pericardial valves have more HALT than porcine valves, which is a thinner, more pliable leaflet. What I don't know, and if any of you are large can help me, have we looked at HALT and ACURATE, which is a bovine supraannular valve? Does it look the same as Portico and other bovine valves?
I think there's multiple factors. It all started with Portico, as you recalled, about 10 years back, 8 years back. So we did quite a lot of study. One factor which affects valves with interleaf position is if you have an underexpanded stent frame. If it's not fully expanded, the leaflets are also going to be kind of folded, and that's where it's going to sit. So if you have a well-expanded valve, or if you do a post-dilatation, you're less likely to see that subclinical leaflet thrombosis after TAVI using internal leaflet position. But there will be many factors which is going to affect it.
I agree with fully expanding the valves is really a crucial thing that you have to do. An underexpanded valve of any type is bad. And even in surgical valves, we learned that the early Ines Gouchali tissue valves that were made too large, then they pinwheeled, that they failed very rapidly. But I do think that some of it's the material, that there's a difference between bovine and porcine. And the reason that all surgical valves are made out of bovine is the early manufacturing wasn't very good, so we needed thicker tissue to sew together. The reason we haven't gone to porcine, even though it's a good material, is that we'd have to go back to the FDA again and spend $100 million. So nobody's going to do it, but we might be better off if all our surgical valves were porcine.
So to that, using that comment, Mike, just a quick comment here is that because we would need to sort of try to strive to achieve circularity, if you will, right? When we're dealing with bicuspid valves, going back to bicuspid, we have like that very heavily calcified raphe, right? That, I mean, unlikely you're going to have like a perfect expansion just because of the nature of the beast, right? Obviously, in that situation, as we talked about before, like the phenotype of the bicuspid, right? In that situation, probably would you, in your practice, favor more the utilization of a supraannular valve because the actually functioning valve is going to be supraannular, not like distorted, sort of? Is there such a thing for you?
Well, I mean, Yoon and Makarov showed us that heavily calcified raphe and opposite leaflet don't do well. And if they're anywhere close to a surgical candidate, we would operate on them. If we're going to do them, we often in my practice use the self-expanding supraannular Evolut, because once you put a balloon in there and blow it up, it may not have enough radial force to put the calcium out, but once it's out there, it has enough hoop strength to resist deformation, and it'll keep itself in the round. But the bicuspid valves that are being treated in the U.S. are a highly selected group. Not everybody's being treated. So what you see in the TVT has already gone through several. I don't know, maybe somebody knows better, but I think like 6 or 8% of the TAVR valves we see are bicuspid valves, whereas at least 30% of that age group should have bicuspid valves. Mm-hmm. So we're only treating the tip of the iceberg, and we're pre-selecting these. And I think the problem is sites that don't really read the literature think, well, bicuspid valves can be tried. Oh, low risk was okay, so that's everybody's low risk, 60-year-olds. Well, there are no 60-year-olds in the low-risk trial.
Sure. Let me summarize shortly in Japanese. So, 後半のちょっとケースに行く前にですね、前半少しだけ日本語で総括したいんですけども、まずマイケル・リアドン先生からアメリカのこの、ハイリスクトライアルと、あとサータビっていうのは中等度リスクのトライアル RCT だったんですけども、それとそのプールドデータと、その外科弁とスープラアニュラーのセルフエクスパンドル、コアバルブシリーズのですね、バルブパフォーマンス、5年までのデータを提示されました。で、5年で、 明らかにですね、その一番新しい定義、バーク3の定義に基づいた、SVD で比較すると、中等度、モデレートの SVD もシビアな SVD も、コアバルブエボルートの方が、サージカル弁に比べて優位に良かったわけですね。でなおかつそれが23ミリ以下という弁輪の小さい弁輪でより差が顕著だったということが、発表されました。でそのモデレート SVD、シビア SVD はいずれもですね、重要なのが死亡だとか心不全とかのそういったエンドポイントにリンクしてるっていうことが、インパクトがあった結果だというふうに思います。でその後に川口先生からそのHALTっていう、現象、多分TAVI治療にフォローアップ含めて関わってる皆さん経験あると思うんですけど、一応現象としてはその CT で、CT 値の低い黒っぽく見えるところですね、それが生体弁に見えることがあると。ただこれはラースが非常に重要な点を提案してくれたんですけど、クリニカルかサブクリニカルかっていうのをきちんと分けてやはりアプローチした方がいいでしょうと。クリニカルっていうのは、クリニカルバルブスロンボーシスっていうのはもう心不全症状があったり、もうバルブの圧格差がうんと上がってきて、バルブフェイリアの兆候もあるような患者さんで、サブクリニカルっていうのは全く無症状で、こういう現象だけ捕まってるということで、全くアプローチが変わってくるので、それを混ぜこぜにしないできちんと鑑別してアプローチした方がいいでしょうということでした。でそのHALTっていうのは自然歴がまだはっきりと分かってない部分もありまして、自然に消滅するものもあれば、途中から急に出てくるものもあるということで、それに過剰に反応して全員に抗凝固っていうのはやっぱり出血リスクの高い患者さんコホートなので、気をつけた方がいいのではないかと、そういった議論だったんじゃないかなというふうに思います。So, should we go for the latter part?
Yeah.
Yeah.
Let's move on.
Yes. Case presentation. Let's go on to the case presentation. First, by Shinichi Shirai. He will present a case, interesting case, I believe.
All cases are interesting.
Thank you very much. To tell the truth, I don't want to present this case because you understand later. So this is a very hard case. I'm a military proctor. So 77 years old man and a severe aortic stenosis with bicuspid valve. And his previous history is esophageal cancer treatment. So as you can see, this is the stomach. So anterior portion. So in front of the sternum, the stomach was reconstructed after resection of the esophagus. And height is 160 and body weight is 50. And the symptom is DOE. So he was referred to a hospital for TAVI candidate. Very active persons, CFS2 and low STS scores and no cognitive dysfunctions and kidney function great, and the BNP level is so high. It's not so high. And this is UCZ. So every EF is 69%, very good cardiac function, but the mean pressure gradient is 86.4, and the peak velocity is 5.81 meter per second. That's a very severe critical aortic stenosis. And as you can see, the type 1 bicuspid, or type 1 or type 0, I can't remember, but the type 0 or type 1 bicuspid with severe aortic stenosis, and the areas are very large. Perimeter is 86.6, and area is 590. And the Valsalva wise is very large, and the lower extremity is good for candidate for TAVI. And so our team decided to implant 29 Evolut R at that time. So at first, 20 millimeters balloons for predilatation, and then implanted Evolut 29. And west, in order to diminish the west, so we post-dilate 22 millimeter balloons. And this is a final angiogram of this patient. And the post-TAVI TTE and the CT measurement findings. So mean pressure gradient is 11.6 and the maximum velocity 2.5 and effective orifice area is 1.5 and our finding of asthenesy. And this is the final CT and post-CT analysis findings. So there is no HALT in just after the procedures. Now 1 year TTE, there's no CT findings, but there's no deterioration of the hemodynamics, mean pressure gradient of 10, and the every effective orifice area is 1.58. 2 years ago, you saw the HALT, 2 cusps, and a little bit worsened, mean pressure gradient 12.6, and if EOA down to the 1.18. And calculated the index EOA is 0.78. But at that time, there's no symptoms in this patient. Oh, so what should I do for this patient?
Thank you, Shinichi. Can you stop here for
Yes.
a moment?
Yes.
And it will be a nice discussion here. By the way, can we do a live poll?
We can do a hand-raising poll if people are brave enough to raise their hand.
Yeah,
Oh, it's cool.
We have a poll here. I don't know if
Okay.
all of you can approach by the app, maybe?
That's probably the app, anticoagulation or observation.
Mm-hmm. Simply raise our hands.
Yeah, let's raise our hands. How many people would put them on oral anticoagulation just based on the CT finding?
Mm-hmm.
Okay. And how many would just watch them?
Okay.
Okay, well, now we're going to get the answer.
Watching is a
Yeah.
Observation.
greater population.
Well, that's probably one person answered.
Sorry, what?
Maybe 3 on the right upper
Okay,
side.
you got to be careful of your statistics there. Now one more person answers and it changes.
Can I finish this presentation, okay?
Yeah.
Yes. So I did that. So as you can see, there's a valve thrombosis in early phase, 1 year, and spontaneously HALT was diminished. All cases in
Can we
early
get his
phase.
slides back up?
Yeah. Oh, can we change slides?
Put his slides back up.
Sorry.
Oh,
Okay.
yes, thank
There
you.
you go.
As you can see, in Evolut low-risk trial, CTE subsidies, so and HALT was diminished and subsided spontaneously in half population. And but everybody shows the presentation. So the valve deformation caused the HALT and the bicuspid aortic valve and a larger canting valve led to a greater degree of asymmetrical leaflet expansion. In this case, bicuspid case, and as you can see, the valve asymmetrical implantation. And so, and the valve, HALT and valve thrombosis are different, but the valve thrombosis causes SVD, and the HALT is diminished the OASIS therapy, as Dr. Kawaguchi said. So, summarize that in this case, not early valve thrombosis. So 2 years later, emerging the thrombosis. The evidences of spontaneous resolution of late valve thrombosis are not well known. The shape of the implanted valve, bicuspid valve, was highly asymmetrical, and the index EOA was 0.78. At this moment, TAVI is not reimbursed in Japan, so I regret. Anticoagulation therapy was initiated in institutions. But 2 years later, now extremely almost diminishing the thrombosis and HALT, and the mean pressure gradient return to the normal, so 8.8, and aortic area is 1.38. So I think the duration of the anticoagulation administration is only 6 months. So 6 months later, I stopped the coagulation. So no longer long administration of the OAC. So thank you very much for all kind of attention.
Well, I think you shouldn't regret anything, because I can tell you I don't have the answer to this. I will be the first to raise my hand and tell you I don't know if it's the right thing to anticoagulate or not. And if you decide, I don't know how long you should do it. I think we're starting to slowly generate the data on that. As I said, when the low-risk 40 CT study came out, and I looked at it with Philip Blanca, who was the primary editor, and Jeff Popma, we just kind of scratched our heads, because just what you showed. Some had it and it goes away. So I don't know if there's a right answer. The answer is if you put them on anticoagulation, it gets better, you did right. If they bleed in their head, you did wrong. So, who knows?
And if we do decide to put patients on anticoagulation, what type of anticoagulation are you guys using? Should we use warfarin or a NOAC for the ease of use? Any comments from the panel?
I can comment a little bit on that. I've had a number of cases of patients who have had both leaflet thrombosis and HALT with varying success with NOAC. So I've actually now exclusively would use warfarin.
Yeah, we always use warfarin. Maybe it's because I'm old and a surgeon, but we found that it works better. Mm-hmm. Patients like that it costs less, but they hate the fact that they're getting their INRs. They now have home testing for INR, and if you do that, it makes it very easy for them to follow their INR. But you have to be on it for a month before they'll give you home testing.
Mm-hmm. Shinichi, in your specific case, what kind of OAC have you selected?
Warfarin, mm-hmm. Yes. But because in some cases, in spite of using the DOAC for aortic AFib case, so in some cases, HALT was emerged in spite of the using DOAC. But after changing to the warfarin, the DOAC is diminished. But it is spontaneous. I don't know which. But sometimes, in spite of administrating DOAC, in some cases, HALT was emerged.
Mm-hmm. I don't know what's scarier, having a HALT or having your stomach outside your chest. I don't know. Either one of those could be kind of bad.
Yeah, so Guy, you nicely raised the potential, deformation in patients with bicuspid valve because of the heavy calcification. Have you done differently to this patient's approach in this specific patient?
You mean like the decision on which therapy to?
Yeah.
Yeah, I think obviously we take into account obviously the phenotype. I like to use this word, but that's what our friend Suhan has demonstrated very elegantly at the paper that Mike alluded to earlier today. That whether or not to decide which therapy we're going to provide to this patient, surgery versus transcatheter valve implantation. If it's transcatheter, then which type of valve we're going to use, right? So obviously, if the patient has a nasty bicuspid valve with a very unfavorable anatomy while being a good surgical candidate, I don't think there's a question that surgery is the best option for this patient, because there are so many unanswered questions in the bicuspid world. Of course, we can do the procedure, that index procedure. We don't know about durability, as Lars mentioned. We don't know about, there are multiple unanswered questions here. So I think we have to take all of these factors into account before we decide which therapy we're going to offer.
Yeah. We do have one question from the audience. Once HALT disappeared, can HALT again recur if you stop oral anticoagulation? The answer to that is absolutely it can. And that's why nobody knows how long you should give it. Do you give it forever and ever? That's not without risk. If you stop at 1 month, is that worse than 3 months? Is that worse than 6 months? I think, at least when I do it, we're just kind of grasping at straws. And we're treating for a while, and then we stop, and then we look and see what happens.
Yeah, actually, this is a very nice question. I recently had a case. We stopped anticoagulation because the gradient became normal and the HALT disappeared based on the CT follow-up. But again, he developed increased of gradient as well as the HALT. So it can, right?
Yeah.
Okay.
I think we
sure.
forgot to mention what a wonderful case that actually was. That was a type 0, quite an ugly. You actually ended up with a very, very good result in that anatomy. And the amount of deformation, obviously right at the annular level, but where the functioning valve in the supraannular level was, the deformation was actually quite minor.
I'm pretty sure the surgeons weren't chomping at the bit to operate on that guy, though. So.
Thanks.
Okay, so we would like to move on to the final speaker, Guy. He will give us a beautiful presentation regarding Evolut FX that will soon come to Japan as well. Guy, please.
All right, so thank you, Yohei, Mike, and all of the members of the panel here. It's my pleasure to share with you a case of Evolut FX. I know there's a lot of excitement in Japan now for the upcoming launch of this device. And I'm going to share, the case is actually a straightforward case, but I would like to emphasize the new features of this device. And also emphasize the fact that there are some things I'm going to mention throughout the case that's a result of the centers that started the implantation of this device. So I'd like to share this and the success and all of the important observations with all of the other investigators on the initial LMR of Evolut FX. So these are my disclosures. So this is an 86-year-old patient that was seen in our clinic for severe aortic stenosis. Risk factors are there. Patient that's a moderate surgical risk patient overall. This is the EKG. I want you to observe that this patient has a pretty tortuous anatomy here, and this is a very relevant point for us to discuss. The utilization of the inline sheath in this situation when with the current generation of Evolut Pro Plus. I'd like to hear after the panel and the folks from the audience who would be hesitant to utilize the inline sheath versus putting a sheath in. And I'm going to show how successfully we were able to overcome that with the inline sheath with the Evolut FX. These are the measurements of the annulus, so 80 of perimeter, a large sinus of Valsalva, as well as the STJ. These are the cusp overlap as well as the coplanar angle. Coronary takeoff, as you can see, looking very good as well. Now I'm going to basically play. This is the case that we did live actually for the other centers that we're going to start the second LMR.
A great point for discussion for us. However, when you look, look at when you go down 3 millimeters.
Can you take the sound off, please? So I'm gonna obviously I don't want to emphasize any aspect of how we do the procedure overall. I want to show you guys some relevant aspects of this case. And I apologize that I'm forwarding here, but there's really no other way for me to do that. So one of the aspects that I want to show, as you could see in the CT, the tortuosity here, if you look at the screen here, I'm sorry. This is so. As you can see here, one aspect to discuss is the way we decided to go with the inline sheath here, despite of the tortuosity, and because we know that with this device we can navigate more tortuous anatomies, more adverse anatomies. So we are removing the 14 French sheath and then inserting the Evolut FX system. I think there's one comment here is that a lot of people don't feel comfortable with this transition and removal of the 14 French sheath and the insertion of the inline sheath. As long as you incorporate that to your TAVI workflow, it becomes like a natural thing to do, and indeed enable you to treat smaller vasculatures, which is actually very relevant for the population here in Japan overall, right? So I want you to also pay attention to the insertion. After we insert that, it went very easily, as you can see. And another aspect to consider is that I'm using a Safari wire in this case. Most of you have been using the Lunderquist wire for the current system, the Evolut Pro Plus. Whereas with this system, the softer wires, such as the Confida and the Safari, they work extremely well. And we've been using more Safari than Lunderquist overall. Obviously, you can still use the Lunderquist when you have very, very tortuous anatomies, but the Safari works extremely well with this device. So another aspect that I want you to pay attention to now, obviously the valve, we're going to cross the arch as usual in an LAO projection, right? And just like the Evolut Pro Plus, it's hard to see here, and I apologize for that, but we're observing, again, keeping the flush port at 3 o'clock, observing the head marker sitting in the outer curvature of the aorta, just like we do for Evolut Pro Plus. And then once we move to the cusp overlap view, right? What you want to see in this situation is the head marker like looking at you, right? It's in a frontal position, if you will. And that's what we have here in cusp overlap. You see the head marker right there facing us. That's a more zoomed position. In addition, another important aspect of this procedure with this device is this. You see where I'm going to start the deployment, which is in the bottom of the pigtail. Instead of positioning the device initially midway through the pigtail, which is basically what we've been doing with Evolut Pro Plus, we changed that because we noticed that when we were doing that, we were having more recaptures for too shallow implants. And this valve, because it's so stable, right, it dives less to the ventricle. So we start that in the bottom of the pigtail. I'm going to fast forward this because this is not very relevant. The implant is just like we do for Evolut Pro Plus. And then, as we always do, we're going to pace the patient, but I want to emphasize, and I want you to see what's happening on the screen now. So now, we reached the point of 80% expansion, and looking at the screen, you can see the 2 golden markers on the left-hand side and 1 golden marker on the right-hand side. And the golden markers are positioned at 3 millimeters from the inflow of the valve, right? So when you see this situation, so 3 millimeters, which makes it very easy for you to understand the depth of the valve, so the 3 millimeters is there. In addition to the fact that you can understand whether or not you have commissure alignments, right? So the position of the golden markers can help you understand whether or not you had commissure alignment in this patient, right? So we're going to take a picture, as we always do, for just like you do for Evolut Pro Plus, right, in cusp overlap. There we go. So picture there, we're probably at 3 millimeters deep. And then we're going to go take that LAO picture, just like we do for Evolut Pro Plus. And finally, we're going to do and assess the hemodynamic results overall. So why is the 3 millimeters depth important, right? So we just published the data of the pristine TAVI study for more than 1,000 patients. And interestingly, right, when we put in the ROC curve the risk of pacemaker, and this is independent of membranous septum or prior conduction disturbance, basically you can see that when you deploy the valve less than 3 millimeters, the risk of pacemaker is as low as 5%, whereas once it becomes deeper, the risk is substantially higher, reaching 22.6%. So 3 millimeters is sort of a magic number, and it's just a coincidence that the golden markers were actually placed at 3 millimeters. So again, this is another case, and that's the picture that you want to see. 2 golden markers on the left-hand side, 1 golden marker on the right-hand side. And with that, right, this is recently published data also from United States, from Gilbert Tang and Sahil Khera. But when you compare Evolut FX versus Evolut Pro Plus, more often when you put the flush port at 3 o'clock commissural alignment was observed of 93% in Evolut FX versus 80% for Evolut Plus. So higher rates of commissural alignment when the flush port was placed at 3 o'clock or away from the operator. So that's very positive. And we were curious to understand whether the position of these golden markers indeed represented commissural alignment. So that's the reason why our curiosity led to us doing CT post-TAVI to understand whether that really was a reflection of commissural alignment. And we just approved this paper on circulation intervention. But basically, the important piece of information here is that when you do have that situation of the golden markers, either 2 on the left-hand side and 1 on the right-hand side, or even distribution of the golden markers, we have commissural alignment or mild misalignment in 96% of the patients. So that's very, very important, very relevant. So only 1 of the patients of our series did not have commissural alignment in that situation. Obviously, we also looked into coronary alignment, and full disclosure here, you can see that the left coronary actually, there's 87% of left coronary good alignment. For the RCA, this is a small sample size, so for coronary alignment, the sample size is a little small, but for the RCA, it's a little bit more difficult. As we know, there are some variations in terms of the takeoff of the RCA, and therefore there's less coronary alignment with that. But we do need the larger sample size for that. So that's the case that I wanted to share with you. I think we're all very excited with starting Evolut FX here in Japan. I think it's a great device. It's indeed a game changer, which basically enables us to deal with more complex anatomies. It helps us to deliver more coaxial deployment and a better understanding of whether or not we have commissural alignment and the depth of the device. Thank you for your attention.
So thank you, Guy. That was an excellent talk. Please come back to the seat. I guess on the panel, you, Guy, and Mike only has the experience for the FX device since it's still not launched in Japan as well as in Australia. So please share your experience so far.
So there's some properties that are intrinsic to the valve, such as the low gradient excellent hemodynamic structural. That's intrinsic to the valve. It happens in FX. It happens in Pro Plus. And then there's other things that I think FX helps address that have been the complaints about the Evolut. One is reliability and ease of deliverability. FX does that. One of the things I teach my fellows is that you put the 3 dots at the bottom of your pigtail, at the bottom of that, and then I have them just let go of the system. Let all the tension, don't hang on to it. It's not going to go anywhere. Just let go of it. And then start deploying without really moving it in or out, and it stays right there. They have to learn to not start high. It's not going to dive. It's going to stay right there. So the ease of deployment, reliability. The other, of course, knock has been, coronary access. Well, you can commissary align this pretty much all the time, as you've shown. Now, it's more important to have left coronary alignment than right, and if they were 120 degrees apart, the numbers would match. But we know as surgeons that if they're not 120, if they're 180, I protect the left and I sacrifice the right. You always protect the left. So, commissure alignment, which will help with coronary access, will help with valve and valve, down the line. And then, pacemaker is just how you implant these things. And I think this is even going to help lower what is now a low pacemaker rate with cusp overlap to even lower, because we're recapturing rarely now because it's so reliable. If you recapture once or twice, you raise your pacemaker rate. If you can do it first time, every time, which it's pretty easy to do with this valve, it's going to lower your pacemaker rate even more. And the last thing is for an old guy like me, when we'd go over LAO and try to find out if it was no parallax, we'd have to cine and I'd have to squint. Now I have those nice little dots that even an old man can see. So it really is going to improve what you do. I look forward to you guys getting your own hands on it and seeing what you think, because it's made a real difference, in how the implantability of these things.
I could not agree more with you, Mike. I think it's, I always say that I think it's a game changer. So I think there are several factors, as Mike very well pointed out. So I think the main, to start the shape of the nose cone, and the flexibility of the capsule, which is better compared with Evolut Pro Plus, that enables you to negotiate more difficult accesses. And as I mentioned, it's a very relevant topic here in Japan, mainly because there are a lot of patients that have smaller vasculatures. So not having to put an 18 French sheath to work through is very relevant. So you can actually handle and deal with more complex anatomies just using the inline sheet. So that's one comment. The other one is that the combination of these features that I just mentioned, plus the fact that it's a single spine only, right, which makes the delivery catheter much more flexible, right, and combined with the fact that there is also a stability layer on the catheter, enables, as I think Mike made a very important comment, which is the fact that you have very little wire manipulation, right, which makes the deployment much more reproducible across the board. So for more experienced and less experienced operators, I think we're getting to similar results, hopefully. That's the goal, right? And a much more coaxial deployment. I think all of us here have faced situations in which we have the valve sometimes very deep on the non-chronic, well, shallow on the non, and very deep on the left cusp, right? That's happened, I think, with everyone here. And with this device, you're going to see that less and less. It's a much more coaxial deployment, which favors implantation in some complex situations, such as, horizontal aortas and etc. And finally, really the ability for us to understand the depth and whether or not to have commissural alignment, I think it's very important. And we were able to validate that with CT post-TAVI. And I think it's very exciting that you guys are getting here. So congratulations.
And we like you do almost all ours in line right now, and I think that the redesigned nose cone has made that easier to get into the vessel. And lastly, when you put this valve in, you make a hole in the artery that's 14 French compatible. When you put a 14 French E-sheet in and then put a balloon expandable, you make a over 20 French size hole, because it's not the sheath, it's the valve that goes through there. So, you just don't see it. But now, when I do carotid access, the sheath hangs out. And when I do a balloon expandable, you see this giant valve expanding the E-sheath as it approaches the carotid artery slowly, slowly. It's a pretty big thing. So it's a big valve. We do have a question from the audience. Is it better to implant in a horizontal aorta? Do you mean, do we rather have a horizontal aorta, or can we do this in a horizontal aorta? Yeah, you can do it in a horizontal aorta. I think having one spine makes a difference, because, as Guy has told you, with two spines, it can just go side to side like a fish, but with one spine, it can make 360. That's one reason why it tends to be more axial.
Yeah, great. I was quite striking that your circulation intervention data, that 90% of the patients have good commissural alignment, right? So, so now a little bit technical question to you, Guy, is that you go to the cusp overlap and you see the 3 dots, right? 2 on the left side is obviously a good sign for commissural alignment. Well, it's a very rare case, but if you find, let's say, 2 dots on the right side, would you recapture and, let's say, go back to the descending aorta, rotate or whatever? Or, well, it depends on the situation of the coronary of the patient and the age, maybe. How would you make a decision on that situation?
I think you already answered the question, right? It depends on the patient you have in front of you, right? It depends on, if it's like a 90-year-old patient that's, I'm not very interested in having coronary access, right? I'm not going to run the risk of bringing down to the risk of the recapture is a phenomenal feature, but it's not, there is a price to pay, right? So they're going to bring down to the descending arch, then recross the arch, which also can increase the risk of stroke, etc. Right? So the decision is, when I step in a case, I always discuss with my fellows the understanding of, if we do not have commissural alignment in this case, are we going to recapture and bring back? Is this relevant for this specific patient, right? So yes, and if it is, and the only way we can know that, right? Of course, you can look at the head marker, but with the golden markers, the only way you're going to know that is when you're 80%, right? That's the thing. So then if you decide that, yes, I'm going to try to achieve commissural alignment, then you're going to have to recapture, as you said, bring down to the descending aorta, then you rotate the flush port and then reattempt.
Yeah, if you went across and you're on the outer curve, and straight in front, and I ended up with 2 on the other side, I would really question what's going on, because I do my own 3 Mencios, and I look at the cusp overlap, and so I know what I should be seeing, so that would be really kind of funky. One thing that also bothers people is seeing that one on the lesser curvature where it's supposed to be, but then you would think the other two would be laying right on top of each other, but they seem to be off, and sometimes they think that's wrong. No, that's because that's an oval. And if you do it inside a surgical valve, they almost always are on top of each other because it's a circle. But most of the people we're dealing with are an oval. So once you have this one here, these two may not be exactly evenly placed. So don't worry about the two on that side. But I don't think I've ever seen two on that side. I've seen a little bit off one way or the other, but it's never been two. That would be...
Right. In addition, Yohei, I showed that the examples that I showed is two on the left-hand side and one on the right. Another favorable picture would be that you have the three dots, distributed evenly. That's also favorable for commercial limb.
Thank you. So one question to Shinichi. A very nice demonstration of the Evolut Pro Plus case yesterday. So in that case, your team chose 18 French sheath. But if you had FX, would the approach have changed?
So thank you very much. Great question. So as a reason not using the analysis in now Evolut Pro Plus, because of the double spine causes non-flexibility. Sometimes the Japanese patient has a very tortuous femoral and iliac arteries, and that is a risk of the vascular complication. But I directly manipulate the FX. It's a very flexible and very easy to manipulate. And furthermore, the tip length is longer than the Evolut Pro system, so very easy to track the iliofemoral artery. So if in near future the FX is reimbursed in Japan, maybe I abandon the 18 French Cs, go to the 14 French Cs inline Cs TAVI procedures. Yeah,
I would really encourage everyone in the room to incorporate the sheet exchange to your workflow. As Mike very well pointed out, right? If you can work in a 14 French hole, right? And while and deliver the valve, right? That's exactly the point of Evolut FX, right? That's great. So you avoid putting an 18 French sheet in, right? And when you incorporate that to the workflow, because some people have resistance to the exchange of the sheet, right? Taking the 14 out and putting it's so easy. Once you incorporate to the workflow, it's like sticking the groin. It's just part of the procedure, right? So once you incorporate that and you're comfortable with that, and indeed, I'd like to hear when you start doing these cases, because we know that the anatomy history is very challenging. It's going to be great for all of us to have more knowledge on. But I really think that's a much better device to navigate through the tortuous anatomies, and I'm sure you're going to be pleased with that. Yeah.
Thank you.
Thanks, Guy, for additional comments. So, David, final question to you. When you start having this nice tool in your shelf, what kind of expectation and what kind of impact would deliver to your clinical practice?
Well, I think we're trying to do less and less alternative access, and there's still the odd case where you might have 5 millimeter femorals, but the calcification and the tortuosity means that, like you said, you're having to think of other options or having to put a sheath up. But once you get to that 5 millimeter limit, you can't really put an 18 French sheath up and then a delivery system inside it. So having something that delivers as well as a sheath is really going to be a game changer. And then the other thing that I really like is the lack of manipulation of the wire. I don't like sometimes the fact that we have to take the tension off the Lunderquist wire, because if you're doing pacing via the LV wire, we generally like to keep it down in the apex. So not having to do that again will be an improvement in our workflow.
Well, when you're forced to do alternative access, our second access is now the carotid artery. And when you do this in line, the hole that you put in is 14 French and it stays there. When I do a sapien to the carotid, I go through and I shove this big valve through, but once the valve goes through, the E-sheath collapses again, and it bleeds around the sheath unless you snare it off in some way. Whereas this makes it very easy, it doesn't bleed. I do have one question for the panel, though. So the Medtronic's color is blue, the Evolut is blue, and they made this one green. How many in the panel wish they'd left it blue?
I like that.
Okay, so I'm the only one that likes the blue. I'm going to get on the Medtronic people. Okay.
Okay, so I guess it's time for summarize. Let me summarize in Japanese for the latter half of the session. So, 前半は先ほど、少しまとめさせてもらいましたけど、デュラビリティですね。一応5年までのデータで、このスープラアニュラーのセルフエクスパンダブルバルブ、コアバルブ、エボルートが、外科弁に比べて、モデレート、シビアの SVD が優位に少ないということが、報告されまして、で、その後に続いたセッションとしては、HALT っていう現象をいろいろ少し、クリニカル、サブクリニカル、をきちんと鑑別しながらアプローチしましょうということと、そのリスクなんていうことについて、ディスカッションしてまいりました。で、白井先生のケースプレゼンテーションですね、2000弁でエボルートを入れて、非常にいいポジションで血行動態もよく追われたっていう、綺麗な症例だったわけですけども、年々フォローしていくと、圧格差が少し上がってきていて、でそこでCT を取ると、HALT っていうのが見つかって、ただ患者さんは症状がない、じゃあどうしましょうかっていうところで、これは正確な答えはないですっていうところで、白井先生の選択は抗凝固追加っていうわけだったんですけども、特に出血などもなく、圧格差も減って、HALTも消えてっていうことだったんですが、ケースによってやっぱり出血のリスクを負うということなので、そこはケースバイケースのアプローチ、ということですね。あとは今日何度も登場したサーキュレーションのファーストオーサーの福井先生自らいいサジェッションいただきまして、やっぱバルブがうまく特に2000弁とかで観察されますけども、やっぱり歪んで入るというか、デフォーメーションがあるとですね、そういったやっぱり血栓とかのリスクにはなるということが証明されつつありますので、特にそういうケースはより注意深くフォロー、場合によっては早めの抗凝固療法もちょっと示唆されたというところであります。で最後ギーからですね、日本で3月以降に始まっていくと思うんですけども、新しい世代のエボルートシリーズ FX っていうもので、改良点としてはまずそのスパインっていうのがこれまでプロプラスまでは2つあったわけですね。それがトラックビリティが良かったわけですけども、一方でちょっと硬いっていうシャフトっていうのもあって、アーチが急峻だったりすると少し抵抗を感じたり、少し工夫して進めていかなきゃいけないっていうのがありました。それが一つのスパイになってよりフレキシブルになって、先ほどの症例もかなりアーチのクロスとかもある意味少しちょっと曲がりながらいい具合にクロスしてたなって印象もありますし、ノーズコーンも改良されたりっていうことでデリバリビリティが上がった。プラス、一番下のところからですね、3ミリのところにマーカーがつくことで、深さがより明瞭に分かる。でその手技がやっぱり再現性があるということですね。で、安定したシステムになったということで、エキスパートからビギナーにも同じような結果が出しやすくなっている改良っていうのが症例を通して報告されました。So Mike, I would like to have some words from you for the final words.
Well, I think this is a great session. I think we went over some really important things. I think valve durability is a growing concern for us because we want to know if this early advantage of TAVR is going to hold up over the long haul. We are all going to be seeing younger patients as time goes on. We're all going to be seeing more complex anatomy as time goes on. HALT is an ongoing thing. I will say that it was very interesting to talk about, but I don't have the answers in HALT. And I think we're all still struggling to find out where we were going to end up with HALTs. I thought these were a couple of really good illustrative cases. And then finally, I really look forward to you getting your hands on FX. It really is a significant improvement in the valve. And of course, the next iteration is going to have FX Plus is going to have big holes for the coronaries when you coronary align. So, I think that we're maintaining the intrinsic properties of the valve, which is hemodynamics and durability. We're adding ease of use and commissural alignment, really important thing. So, Yoshi, great session. I think it represents care where we're going in the future.
Thank you very much for your participation.